Welcome back in another video discussion. In this episode, in this video discussion, we will discuss about the management of anti TB drug induced hepatitis. So let's start our discussion for today. So before discussion, we should understand the definition of ATT induced DIH. When we call drug induced hepatitis, when we have one is clinical symptom, the patient having abdominal pain, vomiting, fatigue, yellowish of the sclera, altered sensorium with liver enzymes ALT and AST rise more than 3 times of upper limit of normal, and with have a jaundice, total bilirubin rise more than 2 times of upper limit of normal. So when they have clinical symptoms along with your liver enzymes increased, then we call it a DIH, anti TB drug induced. Or if there is no clinical symptoms, in that situation we take upper limit of liver enzymes rise up to 5 times. In that situation we also call it as a drug induced hepatitis. So who are the risk patients? These are the patients who have a more chance for developing drug induced hepatitis. So they fall, these are the patients like with history of underlying liver disease, if they have suffered in their past like jaundice, ascites, GI bleed, they have a physical findings such as of liver disease like splenomegaly, ascites, icterus, edema. These are the patients having high risk for developing DIH. Alcoholic patient, we know hypolipidemia and malnutrition, they are also the patient who have a very high risk for developing DIH. And elevated aminotransferase at the baseline. If the patient is having elevated LFTs before the start of treatment, they also have a very high risk for developing drug-induced hepatitis. HIV patient has another risk. IV drug abusers, they are also on a high risk group. Elderly age, they can also develop DIH when you treat them for tuberculosis. So we know that hepatotoxic reaction to anti-TB drug may be more common among these patients, and they should be, therefore it should be anticipated early in these patients. All right. Certain points are important to know that patients with the past history of acute hepatitis or jaundice do not require change in the standard first line of treatment. If somebody has suffered episode of jaundice or hepatitis in the past and recovered from that, so in that patient, in these particular patient, there is no need to modify anti-tubercular treatment. They can be prescribed standard anti-tubercular treatment with the close monitoring of the LFTs. All right, and the number of hepatotoxic drug used in this setting should based on the severity of liver disease. So we have to decide anti-tubercular treatment as per the seriousness of the liver dysfunction, how much liver is affected and what is the level of liver disease. Is it chronic liver disease or it is acute liver disease? What are the liver enzymes? So if the patient is having liver disease, we design our regime based on the hepatic profile of the patient. All right, and we know that hepatotoxic drugs in the first line are most commonly, these are the pyrazinamide, most hepatotoxic drug, isoniazid and rifampicin. These are the drugs that can cause drug-induced hepatitis. Fluoroquinolones also in the rare situation can also cause hepatitis, but very less commonly seen. Most commonly it is seen with the pyrazinamide and isoniazid, rifampicin. So how to manage a hepatitis induced by anti-TB treatment? It depends on number one, whether the patient is in the intensive phase or in the continuation phase of TB treatment. We should also take into consideration the severity of the liver disease, how severe is the liver dysfunction, the severity of TB also, if it is life-threatening TB or non-life-threatening TB, and the capacity of the health setup to manage the side effect profile of the TB treatment, and means simply where we are treating the patient, whether we are treating a TB patient in a hospital setting with all fully equipped lab facility available, and whether we are treating this patient in the remote areas, CHCs where there is a limited facility of lab profile is there. So in that situation, we should also think that where we are treating this patient. All right. So this factor should always be considered when we are treating a case of DIH. All right. So how to proceed? We have started a patient, we have diagnosed the patient with tuberculosis, we have planned to start him on ATT, and now we have just discussed the risk factor of ATT hepatitis. If this patient fall in this category, having a risk factor for ATT induced hepatitis, if that is yes, then this patient should be evaluated for the underlying liver disease. They may have underlying liver disease. We should do a HbSAg, we should do anti-HCV, we should do ultrasound scan to see the liver status. And if the chronic liver disease is diagnosed in this patient, in that situation, intensive education and counseling is needed. We should modify ATD that based on the child POG status. We will study in the subsequent slide, and we should do a frequent LFT monitoring. So if patient is having chronic liver disease, we have an entirely different regime for these patients. Usually we do not give pyrazinamide in such patient with the established chronic liver disease. All right. And if there is no chronic liver disease or there is no cirrhosis, we can start anti-tubercular treatment. We should counsel about the DIH symptoms. that the patient should report to us when they develop symptoms of drug-induced hepatitis. And if there is no risk factor for ATT hepatitis, then we can start on ATT, but still this patient should also be counseled for propensity or for developing DIH, but not all the patient will develop DIH. So they should be informed about the symptoms, that if you are having nausea, vomiting, yellow sclera or decreased appetite on anti-TB treatment, they should come back to us for the regular follow-up. All right. So we have started him on ATT, and now patient developed a DIH. So how to diagnose? We have just discussed that there should be clinical symptoms like abdominal pain, vomiting, unexplained fatigue. There should be yellowish of the sclera. And they also present with altered sensorium and enzymes. If you do, that will be increased to the 3 times of the baseline, and jaundice may be there. All right. And but they sometimes they may not have any clinical symptoms, but the liver enzymes will be sky high after 5 times of your baseline or upper limit of norm. So in these patients, we should do a exclude viral hepatitis. We should also look for the other causes of hepatitis. We should rule a viral cause. We should do an ultrasound scan to see if there is abnormality there or not. We should do a PTINR, and we should do an ultrasound scan of the liver. After that, we should stop all hepatotoxic drug. That is a core concept when we are treating a patient with hepatitis. So we should want liver to take rest. So our fundamental concept is to provide rest to the liver. So we should stop all hepatotoxic drug, and we should address the patient that is there any need for anti-TB treatment or not. If the patient is seriously ill, if the patient is having serious forms of tuberculosis, we cannot just stop anti-TB treatment, but in that situation, we should use anti-TB treatment. These are drugs which have a liver safe profile. Okay, so in the desperate situation, in the serious forms of TB, we have to give anti-TB treatment, and we should modify our regime anti-TB treatment based on the liver profile, or we have to use the liver safe regime in those situations. But in the condition where the TB is not seriously ill, patient is not very sick, so we can just stop anti-TB treatment and let the liver to recover from his acute injury. And once LFT is back to normal, we can restart the anti-TB treatment. So if there is no need for urgent anti-TB treatment, repeat LFT after a week and reintroduce. Meanwhile, we treat the patient with conservative medicines. Okay. And if there is a non-resolution of LFT abnormalities, exclude alternative cause of liver disease. For example, if the patient, we think that patient have a drug-induced hepatitis because of anti-TB treatment, we have stopped anti-TB treatment, but his LFT parameters are not improving. So in that situation, we should also think of other differentials, other diagnosis along with your, it could be something else. The patient may have underlying disease also. So we should investigate further other disease in that case. Okay. And if there is a jaundice, if there is a coagulopathy, patient is bleeding, or patient is the encephalopathy, shift this patient to the higher centers for a better care. All right. So we want to summarize here that if the patient develop acute hepatitis and patient is on anti-TB treatment, first we have to rule out the other causes of acute hepatitis, and if the patient is having life-threatening TB, we cannot stop ATT. We have to give him the patient on anti-TB treatment. So in that situation, we will use the liver safe regime. All right. And if the patient is having non-life-threatening TB, we can just stop, defer ATT, we can just stop ATT and let the liver to recover from the acute injury. And once LFT back to normal, we can start him on an anti-TB treatment. All right. So we should know that what are the urgent ATT, that it is a life-threatening, life or organ-threatening tuberculosis is sputum positive pulmonary TB cases where we cannot stop ATT, TBM or tubercular meningitis, CNS TB, pericardial TB, and any form that is life-threatening. For example, intestinal TB with intestinal obstruction, ocular TB, joint and spinal TB. So they can be, if they are threatening to their life, then we cannot stop ATT. We have to give them ATT, but liver safe regime. Where the condition where there is no need for urgent ATT, that is your sputum negative pulmonary tuberculosis, tubercular lymphadenitis, tubercular pleural diffusion, tubercular ascites, and intestinal TB not causing your intestinal obstruction, genitourinary TB and bone TB not threatening to the life. So in this situation, we can just hold the ATT and let the liver to recover from acute injury. Fine. So how do we manage? So we manage. The core concept here lies is the fundamental concept is just provide rest to the liver. Let the liver to recover from its acute insult, acute injury, so that liver can reboot and it can cleanse itself, it can detox, and we support this by providing conservative treatment. So first, we have to decide whether to stop or continue modified ATT depending on the clinical situation we just discussed. And we have to maintain a proper hydration. We have to give the adequate energy for the patient and diet modified as per your liver profile. Usually, we give fat restricted high carb diet, that is blunt and easy digestible diet. Okay. We can also use proton pump inhibitors. We can give antiemetics to manage its symptoms. You can also use UDCA tablets like urodeoxycholic acid tablets too, especially they are helpful in the cholestatic pattern. And you can also use hepatoprotective syrups like containing L-ornithine and L-aspartate. They are found to useful in the many studies. You can also use syrup the patient is having constipation, and by doing this we have to monitor the patient, we have to monitor the lab profile, we have to see the LFT parameters, and accordingly we have to plan reintroduction of anti-tubercular treatment once the patient is stable and LFT parameters are improved. All right. So when to reintroduce? Reintroduction of ATT is we have to consider only if ALT or AST are less than 2 times of upper limit of normal and the bilirubin comes back to normal. So in that situation, we have to start the reintroduction of our anti-tubercular treatment. So two things are there. We should start one drug at a time. That will help us to identify the culprit drug. That rifampicin may be introduced at 10 mg per kg doses. After 1 week, we can add isoniazid if LFT is normal, and after 1 week of adding isoniazid, we can add pyrazinamide 25 mg per kg if LFT is normal. Okay, and if ATT hepatitis is severe, if the hepatitis was severe, that was liver failure, coagulopathy, and ultrasensorium, pyrazinamide reintroduction may be avoided in that situation, because fulminant liver failure and severe hepatitis, reintroduction of pyrazinamide is not advisable, because pyrazinamide is a most hepatotoxic drug among the first line anti-tubercular treatment. All right. So, and another approach is we use one drug with the lowest doses, and that is called drug ramping. Adding one drug in lowest doses, and after that, if LFT, monitor LFT after 3rd days and increase the dose of the administered drug previously. All right. So, and that one by one we add one drug. And this very important point on the duration of ATT, that is counted only when the full ATT is started. For example, if we have planned to give anti-tubercular treatment for a patient for 6 months, and if the patient develops in between DIH, and it took 15 days or 20 days by for the patient to recover from the DIH and to shift on the standard ATT. So that 20 days will not be counted in anti-tubercular treatment duration. So his duration will be extended to 6 months and 20 days. So that 20 days we will not count in between that the patient was on DIH and on modified anti-tubercular treatment. All right. So this is very important that we should count the duration only when full dose of ATT standard doses are started. So there are two methods how to reintroduce. Method 1, method 2. Method 1 we call a sequential, we have just discussed. Second is incremental. In sequential method, what we do, we initiate one drug at a time in a full dose. Rifampicin we start with 10 mg per kg. After 1 week we do a LFT. If LFT is normal, we add isoniazid. After 1 week we can add pyrazinamide in the full doses. And if after adding drug one by one, if LFT increases, then we should know the offending drug and we can stop that drug, and we can use an alternative drug for that matter to make our regime. All right. Step 2, that is method 2, is your called incremental method. What we do here, we usually initiate with the rifampicin 150 mg per day, and we gradually increase the dose of the rifampicin. At day 4, we monitor LFT after 3rd days. If LFT is normal, we increase the rifampicin dose and take another LFT after 3 days. So if the patient is tolerating rifampicin, LFT will be normal. And after the full dose of rifampicin is introduced, you start isoniazid, giving isoniazid 100 mg per day, and again do a LFT after 3rd day. And if LFT is normal, go to the maximum possible dose of isoniazid, and after that do a repeat LFT after 3rd days. And if LFT is normal, then add gradually pyrazinamide. All right. So by doing this, we will able to know which drug is culprit, and if the drug is offending drug is a culprit drug, we have to stop that drug. We have to replace that drug with another one, or either in that situation sometime we have to extend the regime also, so that we can plan as per the case to case basis. Fine. So what is the alternative regime depends on which drug is culprit as the cause of hepatitis. For example, we have started one drug at a time, whether it's a sequential, whether it's your sequential method or the incremental method, and we are able to find out the culprit drug. So what we do in that situation, we cannot use the drug again, so we have to eliminate that drug from the standard ATT. So in that situation, we have to either replace the drug, or in some situation we have to extend our regime. Okay. So for example, if our culprit drug is R, so rifampicin is not used, rifampicin cannot be used. In that situation, alternative regime will be 2 months of your isoniazid, ethambutol, streptomycin, followed by 10 months of H&E, that is isoniazid and ethambutol. So here you can see the duration is increased or prolonged. Okay. If we cannot use isoniazid, So in that situation, we can use 6 to 9 months of rifampicin, ethambutol, and pyrazine. Fine. And if we have to omit the pyrazinamide in intensive phase, then we can plan the regime for 9 months of HRA. Is 9 months for isoniazid, rifampicin, ethambutol. We can plan for the patient. Fine. If at all we are not able to use isoniazid and rifampicin, that has to be omitted from the regime, then in that situation we can use 18 to 24 months of your streptomycin, ethambutol, and quinolones for these patients. Fine. So here comes another important point, that how to reintroduce anti-tubercular treatment in a resource limited setting or in the remote areas. Some physicians are working in the very remote areas, CHC, PHC, where they have a very limited resource available. Even the lab parameters, lab profile are also not very equipped. So they have stuck with the situation in that situation. So what we do in these settings, because we know that our program provides fixed dose combination drug. As per NTP, there is a one tablet including that introduce all the 4 drugs in one tablet. Okay. So and single availability of single drug is limited or maybe not there also. So what to do in that situation? So if there is non-availability of a single anti-TB drug, approach to reintroduction depends on whether the hepatitis or jaundice occurred during the intensive phase or in the continuation phase. Fine. So if we do not have availability of a single drug, then we have to check that whether the patient developed DIH in the intensive phase or a continuation phase. Based on that, we can have some idea about the change of the regime. We can plan accordingly. Okay. So if the patient developed hepatitis or jaundice during the intensive phase, and once hepatitis has resolved, we can restart the same regime, except we have to replace pyrazinamide with the streptomycin. Replace pyrazinamide with streptomycin to complete 2 months of your initial therapy, followed by rifampicin, isoniazid, and ethambutol for a 6-month continuation phase. So in that situation, our regime will be 2 months of HRES plus 6 months of your HRE. Fine. And if the patient develops hepatitis with jaundice in the continuation phase, so how we should proceed? Once hepatitis has resolved, we restart the isoniazid and rifampicin with ethambutol to complete a 4 month of CP with 3 drugs, that is isoniazid, rifampicin, and ethambutol. Fine. So this is the approach we can apply a clinical sense for the patient who developed DIH in the resource limited settings or in the remote areas. Now here comes a question that management of tuberculosis in the pre-existing liver disease. How to treat the patient who have a pre-existing liver disease, maybe a CLD, maybe cirrhotic or alcoholic liver disease, and how to treat tuberculosis in such patient. So we have just discussed that these are the risk factors for developing ATT-induced hepatitis, and we should always anticipate this patient of having a more chance of developing DIH. So if the patient is having pre-existing liver disease, so in that situation, we should do a baseline LFT at the start of treatment. Fine. So we can able to understand what their baseline LFTs are. Okay. And if there is a more unstable or severe liver disease, we should use a fewer hepatotoxic drug should be in that situation for the obvious reason, because in that situation we have to use the drugs with the minimum hepatotoxicity. Fine. So if we normally what we do in chronic liver disease, we categorize the patient in the child A, B, or C category depending on different parameters, and also we do a calculate the MELD scoring, and we categorize our patient in 3 categories: child A, child B, and child PUC C category. So in for child A, we can design a regime containing 2 hepatotoxic drugs. So here treatment recommendations are for 9 months of HRE that we can use, or we can use a 2 months of HRE. S or L means streptomycin or levofloxacin plus 6 months of your HRE, that is isoniazid, rifampicin, and ethambutol, or alternatively we can use here 6 to 9 months of your RZE. All right. And if the patient is having a child B, following the child B class, in that situation we have to design the regime containing 1 hepatotoxic drug. In that treatment, our regime will be 2 months of RES plus 10 months of your RE. An alternative you can use for 9 to 12 months of your RLA, that is rifampicin, levofloxacin, ethambutol, plus minus we can use streptomycin if as per the availability, or for amikacin also we can consider. Fine. If the patient is on the child C category, a very advanced liver failure, very serious forms of cirrhosis or end stage liver disease, in that situation and they have a very high MELD score, so here the regime will contain no hepatotoxicity. In that situation, if we have to treat this patient, we can use this regime 18 to 24 months of streptomycin, levoflox, and ethambutol. Fine. So little bit about your child A, B, and C, and what is the MELD scoring. We should just, it's a scoring system that is designed based on your these 5 parameters: ascites, encephalopathy, total bilirubin, albumin, and prothrombin time into class A, B, C, depending on their derangements of the liver function. And basically, this is categorized to know the severity of your chronic liver disease. So, this scoring signifies how severe the liver disease are. Okay. So, and also there is a model for end stage liver disease. MELD scoring is calculated. It's a log form. It's a mathematical calculation that also have it predicts your mortality in patient having cirrhosis or end stage liver disease. So, based on this category of the patient, we design our regime for anti TB treatment. All right. Here comes another important point, that how to design ATT in the patient admitted to ICU with multi-organ failure. So, many times a patient is admitted in ICU, they have a multi-organ failure. So, in these situations, the certain point that should be kept in mind, that is for drug sensitive TB, we should at least give 3 drugs to them. All right, we should start them with the 3 drugs, and we should adjust the dosing as per creatinine clearance, because they have a deranged renal profile and the deranged renal profile also, and sometimes they have a coagulopathy underlying. All right. So, we have to look all these factors and we have to design our regime, and we should minimally use at least 3 drugs, and we should always do a CB net to know the rifampicin status. Where if the patient is intubated, we can do a endotracheal aspirate, or if there is any pus anywhere in the body, we can get the pus for CB net and culture in the, we can do a CB net. So, we will just discuss this thing. So, here we should know that what are the drugs that are safe in the deranged liver function and what are the drugs that are safe in the renal function. Okay. So, we know that rifampicin cannot be used in the if LFT are deranged, but it can be used when the renal function is deranged. All right. Anastrozole, it is not safe in the liver disease, but it is safe in your renal function. Okay. Ethambutol is safe when the renal liver profile is deranged, but it is used cautiously, or it is used 3 times weekly dosing as per creatinine clearance, especially in the patient is having a deranged renal profile. Pyrazinamide, yes, it cannot be used in the deranged liver function, but it can be used 25 to 35 milligram per kg body weight of the patient 3 times per week, not daily. And that again as per your creatinine clearance and or the patient is on hemodialysis. Right? Streptomycin amikacin, it can be used in the liver dysfunction, but it's better to be avoided in renal dysfunction, but it can be considered. So, if you want to give streptomycin or amikacin, better to consult with your nephrofellow, and we can plan the treatment accordingly with a discussion with the nephrofellow. All right. Cycloserine, it can be used safely in case of liver dysfunction, and however, in the case of deranged renal function, you can use 25 milligram OD with a creatinine clearance is less than 30 ml per minute or on hemodialysis, or you can alternatively you can use 500 milligram per dose 3 times per week. All right. Moxifloxacin is safe in both conditions, in case of liver dysfunction also, in case of renal dysfunction also. Linezolid, it can be used in liver dysfunction, also it is safe in the renal dysfunction. But here we should do a monitor the LFT. So, these are the certain drugs for the basket where we can pick up the drug and to modify or to choose the regime at least with the 3 drugs, fine, based on the liver and renal profile of the patient. So, if LFT is normal and KFT is abnormal, so a possible regime with 3 drugs can be moxifloxacin, H, R plus minus ethambutol. Ethambutol we can give, and if LFT is abnormal and KFT is normal, in that situation you can use moxifloxacin, injection streptomycin or amikacin plus ethambutol. And if both are abnormal, if LFT, KFT both are abnormal, then we can use moxifloxacin, linezolid, injection amikacin or streptomycin as per availability, and ethambutol. And ethambutol doses are modified as per your creatinine clearance. Right? So, remember, but what happens sometimes drugs cannot be used, this regime is not possible. So, in disparate situation we can use second line drugs because we are treating tuberculosis. So, if our regime is not complete with this one, so we can also pick up the drugs from the second line to complete our regime, because we know that we are treating tuberculosis and tuberculosis must be treated with the appropriate regime. All right. So, in that situation, disparate situation, if we have to pick out the drug from the second line, we can also pick up this drug from second line. All right. And always in this situation, always involve the TB specialist or pulmonologist for a better regime. So, finally, to conclude, ATT is the most common cause of DIH, we know, and we should use modified ATT as per the clinical conditions, severity of the TB and the lab profile of the patient. Never compromise ATT regime. That ATT regime should be strong enough to cover, to treat properly, and discuss with the pulmonologist or a TB physician to design a better regime for the patient as per the clinical condition of the patient. And this is very important to know that duration of ATT that count only when the full dose of ATT is started. All right. So, that period during which the patient was on the alternative treatment is not counted. Okay. So when the full dose of ATT was started, then from there you count the duration of the anti. All right, thank you so much. Hope this session is useful. So if this video is helpful, share among the friends and the physicians who are involved in the TB care so that they can find some useful content in this video. See you all in the next video. Keep watching and keep learning. Thank you.